Welcome to the Australian Dental Council Explainer podcast.
Thanks for having me on again.
Oh, absolutely. So imagine a patient sitting in your dental chair,
Okay.
and they've got this massive gaping hole in their upper molar. I mean, it just looks disastrous, right?
A total crater.
Exactly. But paradoxically, they feel absolutely zero pain when they chew their food.
Which is always a bit confusing for the clinician.
Right. Your gut instinct, especially if you're, a busy clinician looking at a badly broken down tooth, might be to just reach for the forceps, extract the thing, and move on.
Yeah, just get it over with.
Exactly. But human biology actually tells a completely different story here.
It really does.
So today we are using the renowned text Odell's Clinical Problem Solving in Dentistry, specifically Case 9, to crack this exact clinical mystery.
It's a great case.
It is. Now, really quickly before we get into it, I need to state that this deep dive is purely educational and evidence-based.
Right.
We'll be discussing specific dental materials, some theories, diagnostic techniques, but this is absolutely not a commercial endorsement of any products, brands, or textbooks. We are solely here to explore the science and the clinical reasoning required to save a tooth that, honestly, looks completely unsalvageable on the surface.
Yeah, and that tension between what looks clinically disastrous and what is biologically salvageable, that's exactly why this case is such a cornerstone of dental education.
Right.
We basically have to strip away our initial assumptions and rely purely on the data the tooth is giving us.
So a massive welcome to our target audience tuning in today.
Yes, woke.
Whether you are an ADC candidate gearing up for those intense OSCE exams, or an Australian oral health therapist refining your clinical reasoning, or, just a dental student anywhere across the world listening in between clinic sessions, we are thrilled to have you with us.
Glad you're all here.
So let's set the stage with the raw data. We have our patient in the chair, they're young, they're fit, and they fall into the category of a casual dental attender.
Oh, we all know this patient.
Right. They never show up for routine 6-month cleans. They only walk through your door when something is terribly, terribly wrong.
Exactly.
And they're presenting with intermittent pain, and a visual inspection reveals a massive cavitated occlusal lesion on the maxillary right second molar.
A cavernous hole.
Right, a cavernous hole. But before we tell you what happens next, we are pinning a comment below, and we want to know right now, pause the audio if you have to, what is your initial differential diagnosis?
It's a really important question to ask yourself right off the bat.
Definitely.
Because formulating that differential, it requires looking past the sheer size of the cavity and focusing on the nuances of the patient's history.
Right, like the fact that they're young and fit.
Exactly. That's our first major clue. But the real hidden gem in Odell's data is their caries risk profile.
Oh, yeah. Because when you see a hole that big, you instantly assume they must have a terrible diet or, terrible oral hygiene.
Which is a very natural assumption to make. But the case notes specifically state that despite them being a casual attender, this is the only carious lesion they've developed in the last 3 years.
Right, which fundamentally changes our approach.
Oh, so?
Well, if we were looking at a mouth full of active, rampant decay across multiple teeth, we'd be dealing with a systemic environmental failure in the oral cavity.
Right, the whole system is crashing.
Exactly. We'd have to aggressively manage their diet and plaque before even thinking about complex restorative work. But an isolated lesion in an otherwise stable, low-risk mouth,
Yeah.
that tells us the overall biological environment is actually working in our favor.
Oh, that makes sense.
Yeah.
Which brings us to the pain profile, which is honestly a complete paradox.
It really is.
The history says the pain is intermittent, and it has recently spiked in severity. But when you ask them to bite down, they feel nothing abnormal.
Nothing at all.
And when you physically palpate the gums over the buccal or palatal roots, there's zero tenderness and zero swelling.
So the location of the pain tells us how far the bacterial invasion has actually progressed.
Okay, unpack that for us.
Well, intermittent pain is the classic hallmark of pulpitis. The nerve tissue inside the tooth chamber is inflamed, and it's reacting to temperature or osmotic changes.
like cold water or sugary foods.
Right. However, the complete lack of pain on biting and the negative response to palpation, those are actually fantastic signs.
Really?
Yeah, it means the inflammation is entirely confined within the hard walls of the tooth. It hasn't spilled out of the root apex into the surrounding bone.
Oh, I see.
So we are not dealing with periapical periodontitis.
Got it. But visually, it is an intense picture. We have this deep lesion right on the occlusal biting surface. The enamel at the margins is completely unsupported by underlying dentine.
Just kind of hanging there.
Exactly. And it shows this opaque, frosty, white demineralization. Plus, Odell's notes that the tooth looks distinctly dark distally.
Yeah, that distal darkness is the visual manifestation of lateral spread.
The lateral spread.
Yeah, dental caries doesn't just drill straight down like a laser beam.
Right, it's not a perfect cylinder.
Exactly. Once the bacteria breach the hard outer enamel and hit the softer, more porous dentine underneath, the decay basically mushrooms outward along the enamel-dentine junction.
Oh.
So that dark shadow. It means the caries has tunneled completely under the surface, hollowing out the tooth and undermining the enamel all the way to the distal marginal ridge.
Wow. Okay, I have to step in here and play devil's advocate for a second.
Go for it.
I'm looking at a young, casual attender who rarely shows up for appointments. They have a cavernous, hollowed-out hole in a second molar way in the back of their mouth.
Hard to reach, hard to clean.
Exactly. Given their history of avoiding the dentist and the sheer structural compromise of that tooth, isn't the most predictable, hassle-free option for both the patient and the clinician to simply extract the tooth?
It's tempting for sure.
Right. Like, why take the risk on a massive restoration that might just fail anyway?
Well, applying strict clinical reasoning requires looking at the long-term anatomical consequences for this specific patient.
Okay.
Because extraction is a one-way street.
Sure.
And in a young patient, removing a maxillary second molar creates a cascade of potential issues.
Is this because of the wisdom teeth?
Precisely. It's due to the totally unpredictable nature of third molars.
Ah, right.
In a young patient, the maxillary third molar might not have even developed yet. Or, if the tooth bud is present, there is absolutely no guarantee it will erupt spontaneously and favorably into the space left by the extracted second molar.
So you could pull it and just get nothing in return.
Exactly. You might extract the tooth hoping the wisdom tooth will seamlessly replace it, only to leave the patient with a permanent gap that compromises their chewing function for the rest of their life.
Yikes.
So retaining this tooth is the overwhelming evidence-based priority.
Okay, so the biological math says we must save the tooth, but wanting to save it and actually proving the pulp can survive are two very different things.
Absolutely.
We've done our visual inspection, we've taken the history. How do we definitively prove this tooth isn't already a lost cause?
We move to clinical investigations, and we start with mandatory sensibility testing.
Mandatory.
Yes. It is incredibly common for clinicians to look at a cavity of this magnitude and preemptively assume the pulp must be completely necrotic and dead.
Because it just looks so bad.
Exactly. But you cannot rely on assumptions. You must apply a cold stimulus or an electric pulp tester. Even with a massive lesion, the pulp has an astonishing capacity to maintain partial vitality.
Okay, so let's assume we do the cold test and we get a vital lingering response. The tooth is alive.
Great news.
Next, we take our radiographs. Odell's text notes that the X-rays reveal an extensive coronal radiolucency.
A big dark spot.
A huge one. The decay is reaching incredibly deep, right into the inner third of the dentine. But here's the most fascinating detail from the X-ray. The coronal pulp chamber looks rounded, its overall volume is drastically reduced, and the pulp horns, that those little anatomical peaks of the pulp space, they are completely obliterated.
Yeah, that is a textbook radiographic finding. We are looking at a real-time snapshot of the body's primary defense mechanism.
Right.
Those obliterated pulp horns aren't missing. They're actually filled with dense, newly formed tissue called reactionary or tertiary dentine.
Oh, okay.
When the vital pulp senses a slow, advancing chemical and bacterial threat from a carious lesion, the odontoblasts, those are the specialized cells that line the inside of the pulp chamber, they go into a state of hyperactivity.
It's almost like the pulp is frantically boarding up the windows from the inside before a hurricane hits.
That's a perfect analogy. And we can actually see those boards on the radiograph.
Wow.
The odontoblasts lay down a thick, highly mineralized layer of new dentine, specifically designed to wall themselves off from the advancing acid and bacteria.
That's incredible.
It is. And on the X-ray, this manifests as a distinct, intact dentine bridge, separating the deepest part of the carious lesion from the vital pulp chamber itself.
Now, before we move on to the actual diagnosis, there is a major radiological pitfall mentioned in the sources here that trips up exam candidates constantly. It's called cervical burnout. If I'm staring at an X-ray trying to find all the decay, how do I avoid falling into this trap?
So cervical burnout is a classic optical illusion.
An illusion.
Yeah. When you look at the radiograph, right around the neck of the tooth, just above and below the enamel margin, you will often see a dark, slight radiolucency on the roots.
Okay, a shadow?
Right. And stressed clinicians and tired students frequently panic, misinterpreting this dark shadow as aggressive root caries.
Oh, man. But it's just a trick of the light, or, well, in this case, a trick of the X-ray beam. Why does it happen?
It really comes down to the physical density of the anatomy. The neck of the tooth is constricted, right?
Yeah, pinches in.
So the X-ray beam passes through this narrow cervical area, which has far less tooth mass compared to the thick enamel crown above it, and less mass than the dense bone covering the root below it.
Oh, I see.
Because there is less tissue to absorb the radiation, more X-rays hit the sensor in that specific spot, creating a dark band. Which is why you must always correlate your radiographic findings with a physical, tactile check of the tooth margins to confirm if an actual cavity exists.
Right, don't just treat the X-ray, treat the patient. So let's synthesize all this unfolding data. We have intermittent pain, no pain on chewing, a vital response to thermal testing, an intact protective dentine bridge visible on the X-ray, and we've successfully avoided the cervical burnout trap.
Yes.
What is our definitive diagnosis?
The clinical picture perfectly aligns with acute reversible pulpitis caused by extensive occlusal caries with healthy periapical tissues.
Okay, reversible.
Yes. The pulp is highly inflamed and angry, but it is alive, and crucially, if we intervene correctly, it retains the biological capacity to heal.
Which shifts our focus entirely, because now that we know the pulp is alive and capable of bouncing back, how do we stop that reversible inflammation from crossing the point of no return into irreversible pulpal damage?
Exactly.
Our immediate clinical objective is stabilization.
Right, and the text makes it clear that the immediate treatment choice must be a definitive restoration.
A definitive one.
Yes. A really common instinct is to just quickly scoop out the soft decay and place a temporary filling just to buy some time.
Right, just patch it up for now.
But consider the structural reality here. By removing all that internal carious tooth structure, you are leaving behind a hollowed-out, severely weakened enamel shell.
Oh, yeah.
If the patient goes home and chews on that temporary filling, the fragile walls are highly susceptible to catastrophic fracture.
And then you lose the tooth anyway.
Exactly. You must provide definitive structural support in that same appointment.
Okay, but let's say a clinician is determined to place a temporary filling first. Maybe they want to, I don't know, soothe the pulp for a few weeks before committing to a massive composite buildup. Odell's text highlights a major chemical pitfall here.
Yes, the eugenol trap.
The eugenol trap.
It's a big one. Eugenol is a compound often found in traditional temporary cements, like zinc oxide eugenol.
Okay.
And it is incredibly effective at obtunding or soothing an inflamed pulp due to its mild anesthetic properties.
Sounds great so far.
It does. The danger arises when your final treatment plan involves placing an adhesive resin composite.
Uh-oh.
Yeah. If composite is your end goal, you must never let a eugenol-containing material touch that cavity preparation.
Now it ruins the bond, but I really want to understand the actual mechanism here. To picture this, for the listener, composite resin relies on a chemical chain reaction to harden, right? Almost like a massive line of dominoes falling over.
That's a great way to visualize it.
Does the eugenol somehow disrupt that line of dominoes?
It completely derails it. Eugenol is what chemists call a radical scavenger.
A radical scavenger.
Right. The setting reaction of composite requires free radicals to initiate the polymerization process, basically, to push that first domino.
Okay.
Eugenol chemically seeks out and neutralizes those free radicals. It essentially catches the falling domino, stopping the reaction dead in its tracks.
Oh, wow.
So if you place composite over a surface previously contaminated by eugenol, the resin will fail to polymerize. You'll be left with a soft, mushy filling that will rapidly leak and fail.
Okay, so eugenol is strictly off the table. We are moving straight to a definitive restoration. I'm looking at our options here. Resin, composite versus glass ionomer cement, or GIC.
The classic debate.
Right. And honestly, it feels like a trick question. Composite is obviously far stronger for a heavy biting surface, so my instinct is to just use composite. Why would we ever consider GIC for a hole this massive?
Well, composite is undeniably brilliant for aesthetics, and it boasts excellent mechanical properties with withstanding heavy occlusal forces.
Right.
However, it's an incredibly technique-sensitive material. It suffers from polymerization shrinkage, meaning it contracts slightly as it hardens under the curing light.
So it pulls away from the edges.
Exactly. To manage this shrinkage and prevent the filling from pulling away from the tooth margins, you have to place the composite in multiple tiny increments.
Which takes forever.
It does, and more importantly, composite requires absolute perfect moisture control to bond.
And getting perfect moisture control in the back of the mouth right next to a cheek that is constantly pumping out saliva, that's a serious challenge.
It's very tough.
Which brings us to the counter-argument for glass ionomer cement.
Right. GIC is far more forgiving. It tolerates a slightly humid environment much better than composite, and it can be placed in much larger bulk increments, which saves crucial time.
Oh, that's a huge plus.
But the real biological advantage is its bonding mechanism. GIC chemically bonds directly to the calcium in the enamel and dentine without needing complex, multi-step acid etching and adhesive resins.
Wow. Plus, Odell's highlights the fluoride release. I've always wondered about this. How does a filling actually release fluoride into a tooth?
So, GIC acts as a chemical reservoir. Once placed, it engages in a dynamic ionic exchange with the surrounding tooth structure.
Okay.
It constantly releases fluoride ions that substitute themselves into the hydroxyapatite crystals of the remaining dentine. This chemical substitution converts the tooth structure into fluorapatite, which is significantly harder and more resistant to future bacterial acid attacks.
So you are literally feeding the tooth a layer of chemical armor.
Exact.
That dynamic bond sounds incredible. But regardless of whether we use composite or GIC, achieving a long-term seal in a wet mouth is still the ultimate hurdle.
Always.
If we are trying to save this pulp from future bacterial invasion, how do we guarantee the saliva doesn't seep in and ruin our peripheral seal?
There is only one acceptable answer for a lesion of this severity: rubber dam isolation.
Rubber dam.
It is the absolute gold standard in adhesive dentistry. By placing a rubber sheet over the tooth, you completely eliminate salivary contamination, you protect the patient's airway from debris, and you create the pristine, dry surgical field required to achieve a hermetic seal.
It's non-negotiable.
Completely non-negotiable. Without that seal, every subsequent step is compromised.
Okay, so the dam is on, the tooth is perfectly isolated. Now we face what has to be the most technically demanding part of the entire procedure.
The actual drilling.
Right. How do we even approach opening up this massive lesion without destroying the whole tooth?
Well, gaining access requires removing all the frosted, demineralized, unsupported, and friable enamel. If the enamel looks chalky or breaks away easily when you press it with a hand instrument, you must clear it away.
Because if we try to bond our filling to weak, unsupported enamel, the moment the patient bites down on a hard piece of food, that fragile enamel prism will simply snap off under the pressure, taking our restorative margin with it and breaking the seal.
Exactly the mechanical failure we must avoid.
Right.
Once we have clean access to the underlying dentine, the clinician has several tools at their disposal: rotary burrs, hand excavators, air abrasion, chemomechanical gels like Caries, or even lasers.
Lots of options.
But the tool is secondary. The true clinical challenge is understanding the microscopic zones of the rot you're cutting into.
Okay, let's visualize the histology of a carious lesion, because it's not just a uniform block of decay.
No, not at all.
At the very bottom, closest to the vital pulp, you have the advancing front where the acid is just beginning to strip away minerals.
Right.
Above that, you have the zone where the dentinal tubules have been widened by the acid, allowing the first waves of bacteria to penetrate.
Yeah.
And then at the very top, closest to the oral cavity, you have the superficial infected layer.
And this histological breakdown leads us directly to the most critical concept for any OSCE candidate: distinguishing between infected dentine and affected dentine.
Crucial distinction.
The superficial layer is the infected dentine. In this zone, the bacterial enzymes have completely overwhelmed the tissue. They haven't just removed the minerals, they have literally liquefied and destroyed the underlying collagen scaffolding in the tooth.
Oh, wow.
This layer is dead, it cannot be remineralized,
Yeah.
and it must be entirely excavated.
But the layer right beneath it, the Caries affected dentine, is a completely different biological story.
Yes. The affected dentine has been deeply demineralized by the bacterial acids, meaning it is softer than healthy tooth structure. However, the crucial difference is that its collagen matrix remains structurally intact. Furthermore, it contains very few actual bacteria.
Right.
Because the structural scaffolding is still there, this dentine retains the capacity to heal and remineralize if the oral environment is corrected.
So the golden rule is we aggressively clear everything away from the outer edges, the enamel-dentine junction, to ensure we get a perfect bond.
Correct.
But down in the deep depths of the cavity, right over the pulp, we intentionally leave this layer of caries-affected dentine.
Yes.
Now, my instinct says leaving any altered dentine down there is risky. Think of it like sealing a potted plant in an airtight glass jar.
Okay, I like this.
If the remaining bacteria in that affected dentine are the plant, and the dietary sugars in the mouth are the sunlight and water, aren't we just leaving a problem waiting to happen, sweeping dirt under the rug?
That analogy actually perfectly illustrates why leaving affected dentine works. Yeah. If your restoration creates a flawless, hermetic peripheral seal, at the margins of your glass jar, you completely cut off the sunlight and water.
Oh.
The bacteria trapped under the filling are suddenly entirely isolated from their oral substrate. Without a constant supply of dietary carbohydrates diffusing down from the mouth, they cannot produce the acid that drives the decay process.
That makes total sense.
The bacteria simply starve. They either die or enter a state of prolonged dormancy. The carious lesion is biologically arrested.
The seal truly is everything.
It really is.
But clinically, when you're down in the dark depths of the tooth with a drill, how do you actually know when you've reached that boundary? How do you know you've removed the liquefied infected dentine but stopped safely in the reparable affected dentine? Visual color is notoriously unreliable, right?
Oh, completely unreliable.
Yeah.
Caries can be pale, and perfectly healthy reactionary dentine can be dark brown.
Exactly.
You cannot rely on your eyes, you must rely on tactile feedback. The boundary zone has a very specific physical texture.
Yeah.
When you run a sharp dental probe across the dentine, the infected layer feels mushy and offers no resistance because the collagen is gone.
Right. It's just mush.
Conversely, healthy dentine feels glass hard.
Okay.
The caries-affected layer sits perfectly in between. Because the mineral is gone, but the collagen that remains, the surface should catch the tip of your probe. It feels distinctly scratchy and sticky.
Scratchy and sticky.
Yes. Learning to recognize that specific tactile sensation is a major milestone in clinical experience.
Scratchy and sticky.
Yeah.
That is the exact feeling we were looking for. Now, before we pull all this together, Odell's mentions an alternative approach for these truly massive lesions where the pulp is perilously close.
Yes, stepwise excavation.
Stepwise excavation, how does that work?
It's a brilliant strategy when you are deeply concerned about a pulp exposure. Instead of attempting to aggressively clear the cavity to the scratchy and sticky layer in a single appointment, you intentionally leave a thick protective layer of affected dentine over the pulp. You place an excellent temporary seal, and you send the patient away for several months.
So we are basically giving the tooth a biological timeout.
Exactly.
What exactly is happening during those 6 to 12 months?
The pulp goes to work. By sealing the tooth and stopping the acid attack, you give the odontoblasts the quiet environment they need to lay down massive amounts of that protective reactionary dentine we discussed earlier.
Building the wall even thicker.
Right, and the affected dentine also begins to remineralize and harden. So when you re-enter the tooth months later for the final excavation, that scary soft layer directly over the pulp will have transformed into hard, dark, highly mineralized tissue.
Which drastically reduces your risk of physically breaching the pulp chamber.
Exactly.
It is incredible how resilient the human body is when we just give it the right environment.
It truly is.
So pulling this all together, successfully managing a massive scarious lesion is never just about drilling a hole and packing it with composite.
No, never.
It requires a meticulous synthesis of the patient's history, interpreting the hidden clues on a radiograph, understanding the microscopic defense mechanisms of the pulp, and ultimately mastering the tactile art of scratchy and sticky excavation.
It is the intersection of deep biological knowledge and precise manual dexterity.
For more dental examination prep tips and clinical deep dives, please subscribe our Spotify and YouTube channel and share this episode.
And I just want to leave you with a final thought to ponder, drawn from the upcoming 5th edition of Odell's text.
Oh, yes.
We are currently witnessing a technological revolution, where artificial intelligence algorithms are becoming incredibly capable of assisting in early caries detection and interpreting really complex radiographic nuances.
It's moving so fast.
It is. But this rapid advancement raises a profound question about the future of clinical practice.
What's that?
As AI and robotic systems continue to evolve, will an algorithm ever be able to truly replicate the delicate, intuitive, scratchy, and sticky tactile feedback of a human clinician's probe?
Wow, that's a great question.
Or will the ultimate preservation of the dental pulp, the true art of knowing the exact micrometer at which to stop drilling, will that always rely fundamentally on the human touch?